Welcome everybody, bienvenue. Merci d'être avec nous. Thank you for being here at Cirka Distillerie. This is a very special place. Again, this is the fifth in our series of MedTech events and fireside chats. We're very excited to continue to be doing this in the Montreal Medtech ecosystem with our wonderful partners, Startup en Résidence from Banque Desjardins. Sarah and Eric are here. And there's a big team from CTS Santé, Christelle, JP. And we are very excited this time to welcome Matt and Rich from BDO. Matt was an attendee for many of these sessions and decided soon after the first one that he wanted to be a part of it. And BDO has agreed to sponsor the event, which is a first for us. And we're happy to welcome Rich, who'd like to say something.
Sure. Thanks, Mark. Thanks, everybody, for being here. So, Richard Yegian, I'm a partner at BDO. I lead what you call the audit practice. It's not a bad word. It's fine. So I lead the audit practice for the province of Quebec. I've been working with life science clients for the better part of 25 years. I actually started with a biology degree and then became an accountant. I can tell you how that happened over a bunch of drinks, but we'll leave that for later. So BDO, we're not BDC, we're not BMO. BDO is an accounting firm. We're the fifth biggest firm in the world, but we are the number one firm when it comes to small and medium-sized enterprises. So a lot of the companies that are in here, that are being worked on in here, are in that space. We are very committed to anything that has to do with technology. So medtech and biotech is especially very near and dear to my heart. And Matt over here, where is he? He's somewhere here.
He's right there. Matt's in the middle.
Somewhere here. Matt works with a lot of emerging growth companies. He's our national emerging growth leader. So he really knows, if you're an emerging company, he really knows how to get you set up. I work with clients that are a little bit more advanced in the B, C rounds and hopefully really good exits for all of you. And we're a full service firm, accounting, tax, bookkeeping, and many, many other services that I won't name right now. So thank you all for being here, and thank you for allowing us to host the session or to sponsor the session.
Rich and Matt, thank you guys very, very much. We really appreciate it. All right, so a little thing about Cirka, you can always count on us to find a really cool place that you don't usually find a MedTech event. And she doesn't want me to say it, but it's all thanks to Tara, as always. She finds these places and she scopes them out. This is a jewel in Montreal. This is a little distillery in St. Henry that is award-winning. It's artisanal whiskey and gin that is voted by Food and Beverage the #1 producer in Quebec right now. So you're in a very special place. And Sean and Isabel have been amazing. They've been serving you so far, and hopefully they'll keep serving you before we leave. So thank you, Sean and Isabel, for everything. And listen, I'm very excited about this topic today. So this is something that I've been talking about for a long time, and I was very, very excited to meet our guest today. She's brought to us by Christelle at CTS, that she said, if you're going to talk about this topic, then you absolutely need to meet Alexandra. And I said, okay. And we got on a call and we finished each other's sentences in the first 30 seconds. And I said, do you want to come to Montreal? And she said, I would love to come to Montreal. So today we're going to talk about, I think, one of the biggest barriers to adoption of new medical technology. I call it, I didn't invent it, it's clinical workflow integration. And I see you smiling at me, Phil. We've talked about this. We're trying to figure out how to get this into the collective consciousness of the medtech community, because personally I think it's the most misunderstood topic and one of the most important, and I think it's the #1 barrier to adoption of new medical technology. So our guest, Alexandra Pelletier, is a Canadian,
yes,
expat living in Boston, and she's lived all over the world, but we like to call her a Canadian because we'll take her as ours. We're very excited. Alexandra is a former White House Innovation Fellow in the Obama White House that worked very closely in the Biden 2016 Cancer Moonshot. And if I'm not mistaken, the goal was to reduce cancer deaths by 50% in 25 years.
By 2047, yeah. So about
That's an
yeah.
incredible goal, and it's still going on.
Yes.
She's also, that was with the National Cancer Institute involved as
That's
well.
correct, yeah.
And also, right now you're working as a strategic advisor with the Cancer X Accelerator, the Moffitt Cancer Center, and you have worked with big Harvard-affiliated clinical centers, Mass General, Boston Children's, Brigham and Women's, and I think the common thread here is the challenge of bringing new technology into these clinical areas, and that's what we're going to talk about today. We're very excited that you decided to come to Montreal. Please, everybody, help us welcome Alexandra Pelletier. So I think I know some of it, but not enough. And Alexandra, you want us to call you Alex?
Sure.
Or Alex?
Yeah, Alex is fine.
It's easier for me.
Yeah, go for it.
Tell us a little bit about your work with startups,
Yeah.
and a little bit about this concept of helping them get new technology into clinical environments.
Sure. So my background is pretty varied. I still don't know what I want to be when I grow up, but I do know that I like to make an impact in healthcare. And as probably many of you know or will know, the American system is very broken. And so part of my effort is to make an impact where I can, and I don't necessarily know where that's going to be. So it's a combination now, after 20 years or so in healthcare. Before that, I was in tech and IBM and Deloitte. But in the last 20 years of healthcare, it's really around how can I look at the great ideas coming out of innovation, technology, coming out of different countries, working in different health systems. What can I really think about in terms of bringing those great ideas to the States? There's a big translation gap. Maybe I will get into that later, but it's an important one. And I think we can learn a lot in the United States by what other countries are doing and doing well in the innovation space. I've also married that with working at these huge institutions, which are not easy to change. It's been a lot of combat, in the trenches with a lot of people for 20 years, and we'll, I think, get into that too. But it's between the two sides of how can we move these big organizations forward, including the federal government at the NCI, and how can we use innovation to spur that, either through transformation, through good ideas, and just through what we know we need to do. So I think that's how it makes the most sense, but we'll see what comes next.
It's certainly a huge challenge.
Yeah, it's fun so far. I mean, I'm going to retire in the next 5 years. He did convince me to come because I haven't been on stage in quite some time.
So part of this is to delay your retirement.
Keep bringing me fun ideas, and I'm in. Yeah,
that's the plan.
Yeah, for sure.
So we talk a lot with young companies about, all of the different challenges. There's so many, but in our interaction with them, we really help them manage the regulatory risk. We call it regulatory risk management. And we know a lot of founders in the room are fundraising, and investors tend to ask the same questions early stage. What are you going to do about the FDA, and what's your go-to-market? And that usually revolves around reimbursement. And we always get the same question. Sometimes from the questions, we know who's asking the questions. Yeah. But the idea of commercialization of medical tech, I still think, is grossly misunderstood. Tell me what your definition of clinical workflow integration is, and do you think it's as big a barrier to adoption as I do?
I am here because I agree with you completely as we were finishing each other's sentences. Right. It is really the last, I said mile, but maybe the last kilometer here. There are a few layers, right? The regulatory is just one piece of it. Once you have that approval, that's great. And I think a lot of companies, even in the States, think that once you have that, then everything else is a checkbox and you're good to go. That's not at all the way it goes. Your regulation and your regulatory seal of approval is just the first step of credibility. And I think it's really important to be thinking about the other layers. I categorize them broadly as your business model. Your clinical credibility, I think, comes before that, actually. So clinical credibility, are the clinicians going to believe it? Are they going to buy into it? Just because the FDA did doesn't mean the clinicians will. And then will your business people buy into it, and why? You don't always need reimbursement. I was thinking about some examples on the flight over here. Most of the stuff I've done doesn't have reimbursement, surprisingly. And so there's other ways to think about the business model. Yes?
I'm sure that's a huge surprise to half the room. Can you go into that a little bit? Can you give us an example of one that is commercialized without a reimbursement code?
Yeah.
Because here, our understanding of, the general consensus around commercialization is attached directly to reimbursement.
And maybe in the medical device area it is, but not in the software, digital health software space necessarily.
Can you talk about that a
Yeah,
little bit?
so I'll finish that. So we've got clinical credibility, business model, and then clinical workflow.
Right.
So you could have all those other things. You could convince the business users, you can convince the doctors, but if you don't convince the person at the terminal, at the computer, or the patient, you're not going to get anywhere.
Right.
And at the end of the day, it's a loop back to the business user to say, did the patients use it? Did the clinicians use it? What was the process outcomes, not just clinical outcomes, but was it feasible? Did you get enough people to do the thing and make it work in order to make the claims of improvement ultimately?
We rarely talk about process outcomes.
Yeah.
How do you even track a process outcome?
Okay, so should I talk about reimbursement first or process outcomes first?
We're going to be here till midnight.
All right, what's the vote? Process or reimbursement?
That's the reason you're in a distillery,
All right.
to keep you here.
Hands raised for process first or reimbursement? Hands raised.
Reimbursement. We got
Reimbursement.
one for
All right.
reimbursement.
Thank you. Okay. All right. So on the reimbursement front, I think what's interesting is again, I come from the land of working with these large hospitals, so that are Harvard affiliated, that are the top world-renowned places. So they have maybe more of a license to operate around innovation than maybe smaller places do. So there is a landscape in the U.S. that has, reimbursement's going to be very important. But to build that clinical credibility, be kind of your first one or two sites, you are going to be probably at these academic medical centers, is what we call them there, that are affiliated with these huge institutions. And there are budgets. But how do you crack open that budget, and how do you think about that budget? So I was thinking about, yes.
But it's not a research budget.
No,
Just
no,
to
no,
be clear,
no.
it's an
no,
innovation
this is
budget.
all operations
Right.
mostly, operations, which is a hard budget to grab.
Right.
But there's a lot of tricks in there that we can talk about maybe after. But my very first project, and I knew nothing about healthcare, and I was talking about it with you on the phone, was a diabetes project. And at the time, there was no reimbursement. This is 2005, so it's before the iPhone. We still had phone jacks in the wall. I mean, I'm aging myself, but we had to get people to plug things into their wall at the time. And there was no remote monitoring code to get blood sugar off of a device,
Of course.
to get it to the nurse in the time for the clinic visit, so the nurse could understand where the patient was at, think about what medication they wanted to titrate, metformin or whatever. There was no reimbursement for that. We had the CEO of Mass General, like the big Uber guy. He was behind it. He gave us carte blanche to do this thing. We had the clinical leadership behind it. They're like, yeah, we should try this thing. Again, this is 2005. And then from within, we still had to convince, this is the last mile with the clinical workflow, the nurse to look at this dashboard before the clinic visit, and the patient to press the button. And so that didn't get reimbursed at the time, and they were willing to do that because they knew that eventually it was going to be better care for patients, a better model of care to be thinking about being outside of the four walls of the clinic. Yes?
It's such a massive. It's just such a massive factor that we don't consider.
Yeah.
Is you want to get the buy-in at the decision-making level. You want to get the budget to start the project. You have to get the tech in, but you're not thinking about those details that are so critical. Will the nurse press the button? Will the patient write the number down?
Yeah.
And maybe we segued into process outcomes. How do you even develop those things and track those things?
Yeah, so another example of reimbursement quickly.
Sure.
So I'm working with
Whatever,
I know, I'm going to get to process. We're totally off the script now, aren't we? Yeah.
I'll ask you whatever you want me to ask you.
No, whatever.
I'll turn this off.
So on the reimbursement side, there are some companies that are looking at it in the States now, but even before you get to the conversation about reimbursement, and not to make it sound scarier, it's not necessary all the time. You can be creative. There are other business justifications. I just want to leave that with kind of the takeaway. Reimbursement codes are not always equally used. So even if there is a CPT code, which is what they're called, it doesn't mean that every institution even that bothers, wants to use it, is worth the time, is worth the effort. And state by state, payer by payer contract, it varies. So even though you have that little code, it might not matter.
Yeah, there's a big misconception that the code is the commercialization.
Yeah,
but
it is not.
there's payments,
Yeah.
there's coverage.
I have yet to really even encounter that as oh, you have that, let's go, ever.
I think just that commercialization without reimbursement is a whole other topic, but
Yeah.
it's certainly opened up. We have other stuff to talk about, but I want to invite people to come up to Alexandra after and ask her about that, because I feel like we could talk about just that.
Yeah, there's a lot of examples around that.
Just that all night.
Yeah.
Do
Process. Do you want to
you
talk
want
about
to talk about process?
Yeah. So process
I
has
do.
changed a little bit, but I think, so now, instead of being in the trenches of getting the patient to plug the thing in the wall and pressing the button, I'm now at the stage where I'm working with larger organizations coming together in order to fuel innovation. So when I started in 2005, digital health really wasn't a thing. Virtual care really wasn't a thing. Now it's a thing. And now hospitals don't have to build it themselves, because we can go to the innovation community and get much better tech, much cheaper, much more efficiently. So now that we're in the space of bringing outside in, because it's always a build, partner, or buy decision, most of the time we should not be building it. Definitely not software in a hospital.
When you say we, you mean
The hospital.
clinical
I've
organization.
got my hospital
Right,
hat on here.
Right.
Yeah.
What are the 3 verbs?
Build, partner, or buy.
Okay, and most often they're not going to want to build.
Right.
Makes
So the
sense.
build shift probably started 2011, out of building in the hospital to innovation, sourcing, if you will.
Okay.
And that's where it really started to transform. So now process measures are interesting, because there's still a leap of faith that people are going to want to buy into your product. And so you have to prove certain things to the hospital or to the hospital buyer or to the clinical team. And the contracts that I've recently been working on the hospital side have something called performance guarantees. And these performance guarantees are, how will the innovation of the vendor company show to the leadership that we're tracking towards adoption and scale? You're not going to expect on day one, unless you're really just a SaaS thing behind the scenes, they're not going to expect on day one that everyone's going to use it and everyone's going to love it. They're going to expect that there's going to be an evolution of adoption in the institution. And so these performance guarantees are a structure around process measures to say, did you get 10 people in the first 5 weeks? What was your NPS score? There's other indicators depending on your technology.
This is phenomenally interesting. Who
Okay.
owns this process? Who in the hospital runs this?
So it's now becoming more common. It hasn't been. So who owns it? I've done it on behalf of a lot of different owners.
I asked the question for a reason.
Okay,
And we'll get to it.
sure.
But the hint is that it wasn't easy to answer. So I'll come back to that.
Okay,
Okay.
so where do you want me to go now?
No, I got it.
Okay.
Listen, I lost my place because we're ad-libbing and it's going so well.
Okay.
There's so much. There's so much involved in what all of these founders are doing.
Yeah.
Fundraising probably primordial, and one of the big problems we have in Canada is that startup founders are spending 11 out of 12 months fundraising, and they take a month off and then they start fundraising the next round again. That's another challenge for another day. But there's so much involved, and at the end of the day, the proposition is bleak. It's extremely risk averse, and it's extremely high cost of change. How do we help young companies, or even intermediately staged companies, start to plan for clinical workflow integration? How do they even start to think about what conversations they should be having and with whom? And what does stage appropriate look like in clinical workflow integration?
Yeah, I think my answer now, like where I'm at now, is different than where it would have been when I started.
Okay.
So I think my answer now is have a very clear idea, with help if you need it from consultants or other people, but have a clear idea of what you think your value proposition is and why, and then have your assumptions clearly laid out. So in the, again, maybe I've been fortunate at these academic medical centers that I work at, but they're very curious, interested people. And so if you're going in there saying, hey, I think I've got this thing, and I think this thing that I've got could be useful to you for these reasons, can we talk about it? They're going to be willing to have a conversation, because you're not going in to say, I want to sell this thing because I believe it's this. Like, you lose credibility very quickly if you go in with what you think the answer is instead of a dialogue. But be very transparent about that dialogue, and you build trust. And at the end of the day, in healthcare, just my belief, and maybe I'm too squishy about this, but it's a human business. And it's a relationship business, and it's a trust-building business. So if you come in with a clear understanding of what you're trying to learn and why, it's going to go well. So for example, yesterday, I was working with a Canadian company, and we had a conversation with a very senior level person in the healthcare ecosystem in Boston. And in coaching the company, they wanted to give a pitch to this senior level person. And I said, don't give a pitch, have a conversation. They're coming in to have a dialogue about what could be possible. The healthcare system is enormously broken, and they want to fix it. They care, they're mission-driven people. But if you come in with a pitch, there's no conversation. And so it was a different kind of shift of gears for this company to have that conversation in an open, we don't have the answers here. This is what we're doing in Canada. What do you think resonates for you in the States? And it's a different conversation than we've got this CPT code, we've got this reimbursement. It was a different dialogue.
I think that's incredibly, that's an incredible point and something that's not intuitive. We always say it's much more than the tech, that the answer isn't in the tech, but that's a whole other level. I like that. It's a human business. Mm-hmm. If you're coming at it from any other angle, you're probably not going to get very far.
Yeah.
People here have heard me say this. I say it as often as I can. The client here or a customer here, we call it the five-headed monster. It's like, it's this consortium of complex personalities. The person that's deciding is not the person who's purchasing, is not the person who's installing, and it's not the person who's using. It's not even the person who's interpreting. Yeah. Talking about the physician finally, who we think is the client, who rarely is. Mm-hmm. And we haven't even talked about the patient who's hopefully benefiting. So, I think we're right on it, Alex. We're talking about approaching these people with a human conversation about things that they care about. But who do we talk to, and what does the value proposition look like for each? Who, at the end of the day, gets your project moving forward? Where do you even start?
It's a bit of an art, but I think it is, again, a human business. So if you're at the clinical credibility stage, it's a different conversation.
Right.
Because you're going to be talking to the thought leaders, the KOLs, maybe in the cardiac unit or whatever, the chief of the department. And unless you get their seal of approval, you're not going to get any farther in the conversation. So that one is pretty clear cut. You get your physicians on board, the important physicians on board, then you get to the next step. And the next step is the business users. And the business users can take different shapes and forms. It could be, depending on the role, I won't get all into it, but there are different people for different reasons on the business side that you need to think through. But then finally, we're going back to clinical workflow here.
Right.
It's probably going to touch a nurse. And the physicians have probably not thought about the nurse. And if there's not a nurse at the table, and you only bring them in after all these other decisions have been made, and then you tell them what to do, and they're already busy. They already haven't probably used the restroom all day because they're in clinic nonstop. They probably haven't even had lunch. And now you're going to tell them to do something else for 3 minutes?
As something extra.
Yeah, and you haven't even brought them into the conversation.
Right.
That's where a lot of things die. And if you don't engage all the users, now you don't have to jump to the nurse over the business user, over the doctors, but you need to say, hey, to the clinician or at the right time, and part of it is a bit of the art and the relationship building, but say, who else is going to be involved in this? Like, how will this be working in your practice? Oh, it's the front desk receptionist has to click that button, or you have to have a sense of who else do I talk to? And if you built the relationship the right way, they're going to be delighted to talk, introduce you to other people and let you know who else to talk to. But you should always know it's not the doctor doing really the thing. It's going to be somebody else, and get them to the table early and get them engaged early. And I don't know if you want to talk about the cookies thing.
I was hoping you were getting to the cookies, yeah.
So we were laughing about
That's
this.
where I thought you were going.
Yeah, no, I'm going to go to the cookies. So early on when I was trying to get, the diabetes thing or the emergency room thing to happen or the inpatient stay thing to happen, I just brought snacks. And I was in the hospital. It was easier for me to bring snacks. But I just brought snacks. I'm like, you probably haven't eaten, and so let me at least bring you lunch. or a cookie or something, and then we can have a chat. And you know
Right.
what? They paid so much more attention.
There's a lot of smiling and nodding and,
Yeah.
and giggling, but you're talking about the human aspect of the business.
It's human,
How many pitches have you seen where the proposition is, I'm going to bring cookies to the CEO's office, right?
Yeah.
It's so counterintuitive, but
Yeah.
it sounds like it makes so much sense when you say it.
Yeah.
My question is, they're in on the workflow. They're not necessarily in on the decision making. So it's very difficult to understand when to engage whom and with what value proposition. But now I'm thinking of something as you're saying it. It's not just integration, it's even development. So we always talk about the KOL network, and we always say develop with physicians, but we never say develop with technicians and nurses. We always say develop with physicians, right? So I think what I'm hearing is ask more questions is the answer. It's not just, okay, we've got a physician interested, let's deal with that physician. It's more like, let's dig a little deeper and find out, well, wait a second, when you get the image, where did it come from, and who gave it to you, and who took the test, and who made the measurement? And it's not just in the potentially the pilot study stage or the integration stage even, but it's even in development.
100%, absolutely. And I think, and I'm going to say yes and, right? So figure out who is in your kind of your network analysis of who should be involved and why, like
Right.
who touches. Like I would write it out on a piece of paper or on a whiteboard for the team to be like, do we have all these things covered? But what it does too is, and I've seen some companies work really hard on a KOL at an institution, and they have a great
Right.
relationship.
Right.
And then that person leaves, or something else happens, or they get distracted, or they have a baby, or whatever, and they're out, and you have no resilience to your strategy at that point. So you want your network analysis going in, and you want your champion, who's going to be the person in the room when you're not in the room, talking about why the organization should take it on, but you want to have more than just them behind you.
Well, we often talk about having, the KOL as the magic representation of the client is a mistake. We always talk about developing a KOL network.
Yeah.
But what you're saying is the KOL network is not just physicians. It's incredibly valuable advice.
Absolutely.
Yeah.
I mean, I don't know what care, I haven't been in Canada for quite some time, but I don't know what care is like here, but
It's phenomenal.
yeah. I mean, it's probably is relative to what's happening in the States. But you're probably, think about your own experience. You probably haven't just talked to doctors, right?
Right.
And if there's
You
something
actually talk to doctors the least.
yeah. So
Yeah.
then it kind of resonates for most of you
Sure.
too, just from an individual patient experience. Like, there are other people in the room that really matter, and the nurse is going to say, "Oh, you know what? I know that Mark had a bad back, and maybe this isn't the right time to add something to his plate." Blah blah blah. Even though you're eligible for the thing, they would have the human understanding of who you are. I mean, it all depends on the care setting, but they would understand.
So
you.
it goes both ways. Yeah, the places where the people are the busiest are a school, an airport, and a clinical center, right? A hospital. And you don't imagine, a pilot and a flight crew walking down the airport and you stopping them and saying, "Excuse me, can you tell me where my gate is?" They always look very busy and they always look very, serious, and you wouldn't even think of stopping them. It's like asking teachers to do extra work. It's the same thing, but we think we're going to bring in this tech, it's going to solve all kinds of problems, and what the staff is hearing is, it's going to take me more time, I've got to train, I've got to learn something, I don't have time, I haven't had lunch yet.
Yeah.
And we don't think about that, right?
Right, and I call that the activation energy. There's so much broken, and there's so many innovators that come and say, "I can make this better."
Right.
And it's like, that's great, you can make it better, but sometimes the bad thing is just easier. And you have to convince that the activation energy is big enough that they will take those 3 minutes.
It's such a crucial factor.
Yeah.
And the fact is, whether we like to admit it or not, because we're on the other side of it, on the innovation side, but physicians will tell you they would love to have your innovation help them save time and do things better and lead to better outcomes, but they've been burned before. And I remember Jack Resnick, the head of the AMA a few years ago, saying the first one was the EHR. And that was in the 70s. They thought, okay, we'll do this computer thing. And it's still the biggest problem, and interoperability is still the biggest problem in healthcare 50 years later,
Yeah.
right? So he was right. He's saying, if you're going to come to us and take our time, then it really had better improve things. I don't think tech is the answer, and I don't think these startup founders are going to find the answer. I think it's a real collaborative. And the same message we keep pushing, it's massively, massively collaborative, right?
Yeah, I mean, I don't know if this is kind of common language here, but we talk about people, process, and tech in that order. So unless you're thinking about the people and you're thinking about the processes that these people are undertaking just generally and why it's so broken and
So
fragmented,
critical. I feel
tech
like
is
asking.
last.
I feel like asking everybody in the room what their three is and what order
Yeah.
it is. I wonder if it would be people, process, tech. I
Yeah.
bet it wouldn't be. I bet it'd be outcomes, and I think that's too big a goal.
Well, the people and the process and the tech, they're all enabling an outcome.
It's supposed to lead to that if you get it right.
Exactly. But if you don't get those three in that order,
Yeah.
then
And
you're not going to get
I mean,
anywhere.
it's really such a difficult challenge because the space that we're in, the space that we're after and trying to change is one of the most complex in the world. It's not just in the U.S., it's everywhere in the world. And I think of my good friend Lee Phillips, who says, you've seen one clinical center and you've seen one clinical center. So, they're all different, and the way you navigate those relationships and those discussions is so different. Let's say you get it right. How do you even start to think about scale?
I mean, I have an opinion and examples. I think scale is still something that is going to take time to sort out in healthcare. I mean, we can talk about why maybe later, but you have one institution that likes your product, and you can't power up 100% of your product for that one institution, because the next institution, the special snowflake, is going to want it
Right.
different.
It's
right?
death by customization.
Yeah,
is what we
death
call
by
it in tech,
customization. Yeah, because you're going to hit a limit, and they all want to see it, especially at the Boston institutions. There is a preference, and they do things in a very unique way that is exceptional and is world renowned, but is different. And so when I worked at one startup, it was about how to say no, or how to limit your product customization to maybe 75%. And it's okay that it's not 100% spot on. Again, it goes back to the relationship. It goes back to being able to understand truly what's a must-have, because you're going to get have-to-haves, the nice-to-haves. You're going to get tons and tons of what about this and what about that, and just figuring out how to package that into product strategy and not do it, because then you're stuck with one institution. And one of the things now, I'm working on something called Cancer X. So for any digital oncology startups here, please find me later and I'll talk more about it. But one of the things we're trying to do there.
It's an accelerator program.
It's an accelerator program. I'm directing it part of the time that I work. And it's about getting international startups applying, and the best international startups get selected by a collection of large champion organizations. So we have Johnson & Johnson, Dana-Farber, Memorial Sloan Kettering, Advocate. I mean, you can look at cancerx.health. So we have all these large, 4 health systems, 1 pharma, 1 payer, and a bunch of VCs and others coming to the table. And part of it, my design of this, is that more than one champion has to pick a startup to be in it in the first place. So it's not just MSK powering company A, it has to be MSK and Johnson & Johnson, or MSK and Dana-Farber, because I don't want this customization risk. If we're going to scale and we're
it's
going to...
built into the process.
Yeah.
Isn't that something?
Yeah, because I don't want to see...
Right.
In order to solve these problems in cancer, right, reduce mortality by 50% by 2047, you can't have one-off, 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 one-off. We need these companies to be able to scale at once, or at least create a product at once that's going to work for whatever champions have stepped up to the table to do the thing.
Alex, that's so great. There are almost 40 startup founders here tonight, and I can't think off the top of my head how many are in the oncology space. But you should take Alex up on her offer. If you're here, now's the opportunity to broach that.
And
for
if
sure.
you have friends that are like, I
Or
really,
right.
I really, really want to see diversity of geography in this. I want to see diversity of founder in this, because cancer affects so many of us, and we have to be thinking in a much more global, diverse way. So that's just my plug. If you know others, let me know. Happy to talk more about it, but passionate about making a change in that space.
And it's a good segue, because you're looking for international candidates. We're in North America in an unprecedented time, at least in my life. We don't need to go into great detail, but we're seeing things that affect us indirectly and things that affect us not just directly, but right in the sweet spot of what we do. Big cuts at the FDA, specifically in digital health and AI, right where we're working, and then strange rehirings and just uncertainty and unpredictability. As an American who knows very well the country here and the ethos here and how startups work here, what advice would you have for us all, actually? Innovators in the room, accelerator programs, governments are here, investors are here, universities are here, we have Canadian clinical centers here. What advice would you have for us to navigate this time?
I think we're all in it together, first of all. I think there's a change, in any administration, especially in healthcare in the States. So it's 16% of our GDP, which is an enormous number. And if any of you have seen the charts of our per capita spend compared to any other OECD country, it's
not even close.
It's outrageous. And what are we getting? Not much. So it's always a key policy issue, being such a large portion of our GDP, and every administration coming in is going to have a different philosophy about what they need to do to fix it. And I think broad brushstrokes, right, you could see Democrats versus Republicans just forever, right, their philosophy of a platform in their party, there's a lot more privatization on the Republican side, and there's more, government programs and services on the Democrat side. So if you go back in history, it's always going to be that ebb and flow of what's the right model. And I think we're going, obviously, back to the pendulum of privatizing some of our core services like Medicare, which is for over 65, and Medicaid, which is for those that don't have the means to afford care. I think we're going to see a lot of cuts in Medicaid. I mean, that's what we're seeing if you follow the maybe boring, wonky budget news. And I think that's going to have a lot of impact. But through all of this, people still need health care, and hospitals are still going to be delivering care, no matter what the financial ebbs and flow are.
Of course.
People are still going to be doing the jobs that they need to do to save lives and care for people. It's just one of the constraints. And so be smart about the conversation, be sensitive about the conversation, be aware of it, and if you don't kind of understand it, it's okay, but be thoughtful. Especially through these changes.
And what kind of indices could we keep our eye out for, and what should we be looking at?
Well, I think the budget reconciliation is something that I'm watching very closely. If Medicaid is cut, I think that's going to have profound effects on state by state. So it's a program, I don't want to get too wonky, but it's a program that has shared funding between the federal government and the states that have Medicaid, and all states have Medicaid, but they all vary.
Well,
So
state-run.
it's state-run with like federal support.
Right.
So if that gets cut from the federal side, then you're going to see states maybe have a different approach to how they're going to solve for it.
It's not going to change Healthtech, for example. There's a significant contingent from Healthtech here actually tonight.
Are you saying age like age?
Age.
Oh yeah. So
Healthtech.
that
It's a
would
huge
be
topic in healthcare
that
right
would be
now.
Medicare.
If Medicare
Yeah.
is going to change, Healthtech is not going to disappear. How
No.
does it change Healthtech, for
Yeah,
example?
so Medicare, I think, obviously there's different parts of it. And Medicare Advantage is the privatized piece of Medicare. So there's the CMS, CMMI, which is the demonstration projects that have a different thing. And then there's the core Medicare service that's federally run. And then there's Medicare Advantage that are payer plans. And those are different, and they can innovate differently. So no, it's not going to go anywhere, but what's your maze that you have to go through might start to look a little different. And there's always a maze, and it's always different, and that's part of the navigation. And that's just something to keep an eye on. But I think Medicare will be interesting to see what happens in the budget for that. But my guess is privatization is the wind of change
so
anyway.
on that shift to privatization,
Yeah.
changes commercialization, how specifically? In the conversations that some of these people might be having with payer networks or provider groups in the U.S.,
Yeah.
The flow of monies is completely different.
Yeah, I think one of the things that I've noted, I've worked with Canadian companies now for 10 years. I work with the CTA in Boston. One of the things that I find is a reluctance or just maybe some limitation of having conversations with payers. And I'm really trying to bridge that gap because I think the payment model is just so different and maybe so complex. And a lot of Canadian startups that I've worked with, it's probably not all of them, but are healthcare, selling to healthcare organizations, provider organizations, when in fact payers are the payer of the service. And so they are, obviously they have a slightly different business model, they have a different place in the market, they have different frameworks, but understanding how the payer works is really important, and Medicare Advantage is a payer service, with a network of clinicians. So really tackling that, if you are going to come to the States, understanding it, because they are an important stakeholder, and probably more so
Well,
in the near
critical.
term.
Absolutely, yeah.
Yeah,
Okay, and I thought of a question that I pinned 15 minutes ago and forgot to ask you.
Sure.
So I'll end on this one.
okay.
Does a hospital CEO care more about saving money or increasing revenue?
Oh, well, okay. They want both, but COVID taught a lot, and I would say the hospital CFO, around the resiliency of what the revenue composition looks like for hospitals. So pre-COVID, it was procedure-based, moving more towards inpatient that would subsidize sometimes the different services that weren't kind of bringing in as much. COVID changed that because procedures had to stop, and inpatient elective surgeries had to stop. And in that, CFOs got an awakening, like, oh, wait a minute, this is a different day, and we need to be more prepared for this day. So now I think, I'm not a total policy wonk in this area, and if you are interested, there are some great podcasts that I would recommend. But it's moving more towards an ambulatory outpatient model. So it used to be like the inpatient stay was where you'd get most of your revenue, and now they're moving more towards ambulatory. And as you move from that inpatient setting to primary care, to outpatient specialty, your revenue is lower. So they're thinking more about that strategy.
But their costs are down as well.
Well,
You're not in the
because
hospital.
they're moving out of the
Right.
hospital, my theory, and I could be corrected, is it's moving more towards efficiency.
Isn't that interesting?
Yeah,
Okay, so both.
because of that
The answer is
shift.
both.
The answer is both, but I think now more efficiency than it has been before, because it's moving to the ambulatory strategy.
It's a great answer. It makes sense. Yeah.
Okay. Oh, we'll see. We'll see
Okay,
what happens.
it's a
Bring me
good
back
time-
next year, and I'll tell you if I was right.
Well,
Yeah.
for sure. We'll do this every year. We'll open the floor to questions. Johan has a microphone, and happy to
Okay.
walk around.
Sure.
Now.
Well, I don't need a microphone. So, what about women's health? How do you see the trend, and how do we get those products in the U.S.?
It might be trickier now than before, given some of the terminology that's less supported broadly. But women are still 50% of the population, and they still need health care, and there still should be a need for servicing that population. I mean, there was, just anecdotally, I'm not in the space day to day, but I am a woman. There has been an uptick, I think, of investment in that space, especially around different service models that have come up, and I've seen a lot of great innovation. I don't think winds die down overnight, but how does that receptivity translate given the environment in terms of headwinds or tailwinds? I don't know. But
Fair.
keep at it. If you believe in it and you think it's going to help people, then it's worth doing.
But the approach is basically the same as the one you've been talking about.
Well, I don't know what your service is, but we can talk about it later.
I coach a bunch of different
Yeah.
startups, so just
A bunch of
looking
different
for-
startups.
yeah.
Okay. I don't know.
I mean, on a high level, it's half the population, and it's massively underserved.
Right, but where are the grant funding, right? Where's that going to be?
Right.
What does it, one of the areas that I think will remain interesting, and maybe this is another space for Canadian companies to think about, is the employer side. It's not easy. There's nothing easy. So I'm not saying it's easy. But the employers still employ women, and they still pay for healthcare. A good, almost 50% of healthcare in the United States is employer-based insurance. So I work at IBM, I get insurance, whatever. So that HR person is going to care
They
about
have interest, yeah.
yeah, about what's happening for my benefit. They call it the benefit plan for women. So it's not going to go away. It just might be a different maze.
It's a great answer, though.
It shouldn't go away. I mean, heck,
I hope not.
please keep
Yeah.
doing what you're doing. I mean,
Yeah,
yikes. Yeah.
fair.
Yeah, totally fair.
Okay,
So-
great question. Thanks. Who else? Over here, yo.
So we developed medical technology, we went to market with it, and in retrospect, it seems like the best course of action would have been just developing an EHR app. So do you have comments on just focusing on the EHR? Because I'm kind of thinking, or give me the counter case why I shouldn't, but I think just the EHR is the gatekeeper, and everyone asks, does it plug into my EHR?
Meaning you have a medical software?
Exactly.
And you realize by being in the field that it would have helped you a lot more to be integrated directly with
I think if they
EHR.
could just find it on the app store of the EHR, you solved at least 50% of your problems.
What are you trying to solve from a human perspective?
It's a cognitive assessment in our case.
For
Cognition general.
Okay. So you're saying should we just be on the App Store for an EHR?
I'm saying is rather than think of it as like a general, but a general tool, or just building in the vid and like just building something, just at least as a first product, build an EHR app.
That won't necessarily get you adoption. And again, it goes back to the whole conversation we're having around clinical workflow. Like just having an app and the EHR, like if a tree falls in the forest and no one's there, is anyone going to hear it? So who are your stakeholders? Why are they interested? And the software package is just one piece of your delivery. But the other pieces that come before it is why they should care to even find you on the App Store.
EHR integration is a huge topic. It's
Yeah.
an adoption barrier that everybody in software has to consider at one point. But I think your answer is, for me, I couldn't agree more. If people don't want to use your software or know that they need to use your software, whether it's in the EHR or not, is not going to make a difference. I think that's what
That's what I'm saying. But there's another piece, and I don't want to be, like, practically, I've struggled even on the inside. I've had the CIO, the CTO, the CSO, the CEO, everybody behind putting something docked into the EHR on the inside. This is
and
now,
it doesn't
it's
uptake.
still hard to do.
Yep.
Now, since then, this is back in 2011, so again, aging myself, but since then, there are these intermediary players. So depending on what you're trying to pull out or push in, there's companies like Redox or Health or others, because there is an understanding that there's this wall around the Epic system, and there's policies that have to break down, or EHRs, right? There's policies that have to break that down for interoperability, for innovation, for all these things, and they've blocked it for a while. So policy is really important, and there's been a lot of push in the United States around policy in all administrations. But then there's these innovative players, well, I guess maybe less so now, that you'd look at as the kind of interface layer to the EHR. So depending on what you're trying to capture or put back in, if it's a hospital that you're going to, like, you know, one of the ones I work at, they're always looking at that innovation space to dock in, because plugging something directly into the EHR, or even if it's in the App Store, there's still going to be a risk and a review and all those other things. So there's just other ways to get in. So I would encourage you to look at Redox and Health and others.
And I do know from others who have developed software as a medical device that made it into EHR successfully, that what they'll tell you, and I can think of one in particular I can even put you in touch with maybe, but what he will tell you is to get good traction and to get people using your software, and the EHRs will come and find you, because EHR integration is a horrible, horrible proposition. And they don't answer calls and emails, because they get 1,000 requests a month from everybody under the sun creating software. And I've tried it for months. They just don't answer you. They don't answer calls, they don't answer emails. But if you do the right steps towards adoption, they will come and find you. You're going to have to deal with the EHR eventually. I don't know if it's the first step. Maybe it's the answer. And 2011 is not that long ago. I was working in.
Yeah, you were working here, yeah. That feels a long time ago.
Yeah, that's not that long ago.
Yeah.
Thank you for all the info so far. So my question for you is, surgeons in the U.S. are very entrepreneurial. They're businessmen. Surgeons, yeah, physician surgeons. In Canada, you can go on the website and you're going to find their email address and they'll reply to you in 24 hours. I'm exaggerating, but not that much. Whereas in the U.S., it's a completely different ballgame. So it can be hard for small Canadian companies to find American KOLs, develop a relationship. And then, I mean, just to pick up the phone, they're going to slap you a bill for $700 an hour. So how do you build that relationship, find them, and then incentivize, or that partnership, whether it's research, grants, or stock options? I mean, I'm just curious to get your general thoughts on how do you engage with American surgeons, build that relationship to start building your clinical affairs strategy without ruining yourself as a Canadian startup?
So each surgeon type has its own personality. So what type of subspecialty?
That would be in colorectal and gynecology for me.
Say again?
Gynecology and then colorectal surgery
Okay.
for cancer.
All right. Those are a little bit more receptive. So I think it goes back to how you want to have conversations with these, like, again, they're limited for time. They have plenty of other
Exactly.
people knocking on their door. I mean,
Yeah.
constantly. So why are you going to rise to the ranks? So you could do it a few different ways. But if you have a surgeon here that has a relationship with a surgeon in the States, start there,
Yeah.
first of all, because then it's clinical credibility just having that conversation. And it's not about buying your thing. You can't go in with buy my thing.
Yeah.
You go in with here's the thing that I'm trying to solve and why. What do you think?
Yeah.
And you're gonna, because buy my thing, they're gonna be like whatever, probably for the most part.
Or help, or let me add to that, or help me develop my thing.
Yeah, and that's what we want. We're not even at the
the
sales
help
part.
you
Yeah.
develop my thing is a slightly different path.
Yeah.
So depending on how mature you are, where you're at, but if you're like help me develop my thing, and you're going to like Stanford or Boston or whatever, they're going to have tech transfer, and then you might get a little bit,
Yeah.
Sticky.
stuck. Or, and it might be worth it. You just have to understand the risk and the trade-off of that versus the conversation of what do you think of this thing. The other place is there's a lot of societies, medical society or surgical society conferences. Go to those because when the surgeons generally, I think when anybody goes to a conference, you're going to have a very different conversation than when you get an email in your inbox
100%.
on a random Tuesday.
Yeah, it's
And
also
so-
contextual, which is very important.
Exactly. So they're going to be more open to conversation in these interesting kind of society meetings as well.
Thank you.
How are you going to answer that question? I want to know how you were going to answer his question.
Well,
Oh, okay. All right.
how I was going to answer it,
Yeah.
how I was going to answer it one-on-one, or how I was going to answer it to get a cheap laugh.
I guess take your pick.
I was going to say, if nurses like cookies, what do surgeons like? Ice cream sandwiches, maybe.
Oh, I don't know. Golf?
No, I think integrating yourself in the community by going to a conference is one aspect of that, but you have to understand whoever you're trying to associate with in any way, you have to understand their language and what they care about. And if you don't have the same language or care about the same thing, then you're just selling something for the heck of it. If you're passionate about something and you care about the same thing, you will eventually engage with people who are passionate about that thing. So you have to find them, unfortunately. And email is the lowest, way to do it, but it's not impossible. But a conference where people are out of their element and already thinking about new ideas and already networking and already looking to be open to things is a much better value proposition than in my day-to-day busy, and you're stopping somebody doing what they're doing. Right? Okay, anybody else? Yeah. This is the question answer.
I know. Come over here for your questions.
Sofiane.
Thank you very much, by the way, for the great insights. I'm learning so much. Organize this more often. I'll come every time.
My pleasure.
Thank you very much. I'm in digital health as well, and I don't know if you're aware of this new shift that we are having today, where people are going more towards B to C to B, in terms instead of B to B or B to B to C, because it's really hard today as an early stage startup to be able to have enough scientific evidence and proof to go and have FDA approval and then go to reimbursement. And what if you do all that and then no one buys your product? Then you have been you would just depress. So that's true.
We're back to, I'm going to try to help you out, ask your question.
Yeah,
I think I
so-
understand. We're
yeah,
back
go
to
ahead.
stage appropriate investment in time, right? Because you're doing so many things. How do you know at what stage? Because the answer is as much of anything as you can as early as possible, which is impossible, right?
That's not
But-
my question. My question is more how about you go directly to patients, you sell to them as a wellness software, for example, and then you start generating real world evidence to go afterwards with that evidence to the FDA.
Oh, you're talking about the pivot from
Yeah.
B2C to B2B.
Exactly,
Okay.
that's the shift. And so do you have any experience in that, or do you have what are your thoughts about that, generating real world evidence and leverage that as clinical data to go and convince the FDA to make a medical device and then leverage it as well to generate medical economic data and go and talk to insurers and to have your device like reimbursed afterwards? So that's my question.
So your second part of your question I can talk to, but the first part, I don't know how the FDA would look at those data sources.
There's things that overlap and things that don't. And Sofiane, we've talked about these things, right? So in a non-medical context, it's not just about the data being applicable to the FDA or not, because that's a very easy thing to answer. To get data that's applicable to the FDA, you have to collect it in a very specific context with their knowledge. Those meet the requirements. They're completely different universes. So for me, the shift between the consumer behavior and the medical community behavior commercially are colossally different. So the website is different, the value proposition is different, the outputs of the software are different, the marketing is different, the conversations you have with each of these markets is different. So how to pivot from one market to the other is not about the FDA for me. It's more about a completely different value proposition in both markets.
Okay.
But there is a perception issue. So when you're medical, you can't sell to the general public, you're blocked that way. But when you're a consumer and you try to sell to medical, you could get a little bit of stigma from the medical community saying, well, that's not really a medically validated product, that's a consumer gadget. So that's what we've talked about is being very careful to separate those two.
Yeah.
That means they're different names. Could be the same device, but they have different colors, different packaging, different marketing, because you want to separate the consciousness of an at-home Fitbit or a $7,000 medical device that is essentially measuring the same thing. Does that make sense?
Totally.
And I would the second part about like then you go to reimbursement, like it's not that easy, right? That your next step there is not kind of because you got the FDA, right? That's a whole other thing that you
very
may or may
complex,
not, like, it depends.
But we also decided that you don't need reimbursement.
You might not.
Yeah.
That was
There
it.
you go.
You might not. I
It's
mean,
a
you might
huge
not need
result
it in the traditional way. I mean, we can talk more about it, but there's a lot of different care models, value-based care, if you've heard of that, that move away from fee-for-service. So reimbursement on a CPT code is generally fee-for-service, but you go into bundle payments or value-based payments.
It's a different thing
It's
altogether.
it's a different day.
Amazing.
Yeah.
Okay, thank you.
Sure, thank you very much.
We have time for one more.
Yeah, I got a quick question. Thank you, Alexandra, by the way. It's been great. You mentioned before in the definition of the users of the device, there's a layer of users that are kind of indirect to the device, that are not directly using your device or your software. How would you go about defining those? I'm talking about the purchasing team, the technician that's going to help set up that device in the hospital. So from the creation of the product, I'm curious if you have any comments on how to define those users, how to think about those users, because they're not the original part of your product. You thought about addressing a need, and then you're trying to integrate that into an environment that requires for a diverse pool of users. So do you have any comments on that? I'll be curious to see.
We're back to early development.
Yeah.
And how to take into account all of these different user characteristics at every stage, which we did touch on a bit.
Yeah. So, I mean, I think it's a great question, and I think it depends. It depends a lot of the time. But the more that you're thinking about what they could be, and you don't, again, have to have all the answers. But if you go to your clinical champion, or you go, to whatever institution that you're working with, and you say, who else should we speak to? Is that part of your question?
Yeah,
I didn't fully hear what your
yes.
question was, but I think you can ask them how to get smart on their organization and that organization's need. And they're going to know it best. And they're also, by even taking you in the first place, taking some political risk. So if they've taken you in that far, they want to see you succeed. And so they're going to help you. If they haven't taken you in that far, they're like, no one else to talk to just yet. You also then know that they're not ready to take the political risk on you. Because every
That's a great
innovation
answer.
is a political risk.
Absolutely. All right, thank you.
Okay, I could do this all night, and I think we're gonna do another topic of just process outcomes.
Okay, all right.
Alexandra, thank you so much
Oh,
for being
thank
here
you.
with us. And thank you
My pleasure.